Good morning. We're all familiar with the PSA, which is serine protease secreted in the prostatic ducts, and it liquefies the seminal coagulant. There are multiple confounders of the PSA, where prostatitis, BPH, DRE, prostate biopsy, cystoscopy, and possibly physical activity increases the PSA. On the other hand, surgical or medical castration decrease PSA, and finasteride decreases it by 50%, possibly ejaculation and micronutrients. The clinical utility of serum PSA, it's not only used for screening or early detection, it's also used for staging and prognosis. The WHO criteria for screening of a disease: the disease must be an important health problem, it must be identifiable at an early asymptomatic age, and the techniques used for screening must be effective, and there should be an effective treatment for patients with localized disease, and the treatment of the early disease must result in improved survival. How common is prostate cancer? It is the most common cancer in men, and it's the second leading cause of cancer deaths in men. Why do we need early detection for prostate cancer? Because of the rising incidence and mortality rates, an aging population, the current understanding of the etiology and pathogenesis limits the use of preventive measures, and the therapeutic options for metastatic disease are palliative in nature. And in the pre-PSA era, there was only 30 to 40% of patients who presented with localized and potentially curable disease. How predictive is PSA? With PSA 4 to 10, it is 30%, shows you the risk of prostate cancer. With a normal PSA, you have a risk of 15%. Above 10, it's 60-70% risk of prostate cancer. We're all familiar with this cartoon where we depict prostate cancer types. The low risk as a turtle, the intermediate risk as a rabbit, and the high risk as a bird. And we all would like to catch the rabbit before it jumps over the fence, because we have a window of opportunity where the disease can be curable. There was a decreased mortality after the introduction of the PSA, with 6% reduction in 1996 in the USA study, and the Quebec study, 15% reduction in 1996. Is this because of earlier diagnosis, or better treatment, or a combination of the two? An evidence for the effectiveness of early detection: there was an Austrian study that began in 1989, and in 1993 the state of Tyrol made PSA available, where organ-confined cancer rates increased from 29% to 67% between 1993 and 1998. Metastatic disease decreased from 29% to 6%, with an 80% reduction. 42% reduction between the observed versus the expected death rates over a 5-year period. The Quebec City Phase 3 PSA screening study, it compared prostate cancer mortality rates between PSA screened and non-screened groups of age-matched men 45 to 80 years of age. It began in 1989 with a follow-up which is relatively short of 8 years. The prostate cancer mortality was significantly, actually threefold, less in PSA screened versus unscreened men. Despite the methodological criticisms in this study, one can conclude that men who do choose to have regular PSA determinations have a threefold lower risk of dying of prostate cancer. We have to remember that those studies were in the early 90s. PSA for the early detection of prostate cancer, with accumulating evidence supporting benefits in the early 1990s. Cross-sectional and longitudinal data showed good specificity and positive predictive value. The incidence was back to pre-PSA era levels after capture of prevalent pool. Proportion of men diagnosed with early curable cancer has doubled, and the incidence of positive lymph nodes at surgery has decreased by 90%. The incidence of metastatic disease has decreased by more than 50%. Prostate cancer mortality rate in the US and Canada decreased by 12%, and the phase 3 data from the Quebec study that I've just presented. All of this supports the position that men who choose to have regular PSA have cancers diagnosed earlier and so should have a lower risk of dying of prostate cancer. All the previous data I have just presented are all non-level 1 evidence. Does PSA screening, does it really save lives? This is what 2 large trials in the US and Europe set out to prove. They were published 2 weeks ago in the New England Journal of Medicine. The first trial was in the US, and it's the prostate, lung, colorectal, and ovarian cancer screening trial on prostate cancer mortality. It started in 1993 through 2001, and it included 76,693 men at 10 US study centers that were randomized into 2 groups, a screening group and a usual care as the control group. Men in the screening group were offered annual PSA testing for 6 years and DRE for 4 years. The subjects and healthcare providers received the results and decided on the type of follow-up evaluation. The usual care group, which is the control groups, sometimes included screening, as some organizations have recommended. The numbers of all cancers and deaths and causes of death were ascertained. The endpoints of this study: the primary endpoint was intention to screen comparison of prostate cancer mortality between the 2 study groups, and the secondary endpoints of collection of data on cancer incidence, staging, and survival. Statistical analysis: the event rates were defined as the ratio of the number of events, which is cancer diagnosis or death, in a given time period to the person years at risk of the event. Person years were measured from randomization to the date of diagnosis, death, or data censoring, whichever came first. For incidence rates and for death rates to the date of death or censoring, whichever came first. The results: the rates of compliance in the screening group, it was 85% for PSA testing, while they had 44% rates of screening in the screening group at baseline. The rates of screening for the control group, which is contamination, was 34% at baseline, came up to 40% in the first year, and as high as 52% in the 6th year for PSA testing. The number of subjects with advanced disease, stage 3 or 4 tumors, were similar in the 2 groups, the screening and the control, suggestive of a pre-screened population of men. The death rates: at 7 years, there were 50 prostate cancer deaths in the screening arm and 44 in the control arm. At 10 years, 92 deaths in the screening arm and 82 in the control arm. After 7 years of follow-up, the incidence of prostate cancer per 10,000 person years was 116 in the screening group and 95 in the control group per 10,000. The incidence of death per 10,000 person years was 2 in the screening group and 1.7 in the control group. The data at 10 years were 67% complete and consistent with these overall findings, with 92 deaths in the screening group and 82 in the control group. Although it was only 67% of the data was complete, they published, and the board found out that there was no significant difference in the rate of deaths between the 2 study groups. And this was not the result of crossing a statistical futility boundary. And out of concern that men and their physicians were making decisions on the basis of inadequate information, they published this, and they found that their data was complete up to 7 years and consistent up to at least 10 years. They also supported follow-up of subjects to 13 years of follow-up. Their conclusion is, after 7 to 10 years of follow-up, the rate of death from prostate cancer was very low and did not differ significantly between the 2 study groups. The second study, which is the European one, the European randomized study of screening for prostate cancer, the main endpoint was prostate cancer mortality. The ages of patients were 50 to 74, with 182,000 subjects. And the core age group was from 55 to 69, with a population of 162 16,387. The screening interval was 4 years in 87% and 2 years in 13%. 16th biopsy was recommended for PSA more than 3. Ancillary tests for PSA 3 to 4. Recruitment and power. The trial started in 1991 with pilot studies in Belgium and Netherlands. The power in screened men, 86% to show 25% difference in prostate cancer mortality at a P equals 0.05 by the 31st of December 2008. 86 power and intention to screen analysis. With adjustment for 18% non-compliance and 20% contamination, the 25% proposed reduction is equivalent to 14% reduction in prostate cancer mortality. So they had 182,000 subjects between the ages of 50 to 74. Out of those, there were 162,000 who were in the core age group from 55 to 69. Those people were excluded because they died, and then they put them into two arms, screening group and control group. With the core age group, screening group had 72,900, and in the control group there was 89,300. They detected around 6,000 prostate cancers in the screening group and 4,300 in the control group. The results of cancer detection and death. In the core age group, there were 124,426 screens with an average of 2.1 per subject, with a positive predictive value of 24.1%. In the screening arm, there were around 6,000 prostate cancer deaths with prostate cancers with 214 prostate cancer deaths. In the control arm, there was 4,300 prostate cancer deaths with prostate cancers with 326 prostate cancer deaths. The follow-up was of an average of 8.2 years with a median of 9 years. Prostate cancer mortality. Relative risk of prostate cancer death was 0.8%, which consisted of 20% relative reduction, with an absolute risk reduction of 7.1 per 10,000 men. Meaning, to prevent one prostate cancer death, 1,410 men would have to be screened and an additional 48 men would have to be treated. Making sense of it? I tried to. This is a table I came up with comparing the two studies. The PLCO is the American one and the ERSPC is the European one. The American had 76,000. The European had 162,000 in their population. And the American was 10 US centers and the European had 7 European countries. The PSA cutoff point was 4 in the American study and 3 in the European study. The lead time in years was 2 in the US study and 4.5 in the European study. The American study was more homogeneous than the European one. At 7 years of follow-up, the American study detected 94 prostate cancer deaths with 0.12% of the population dying of prostate cancer, and the European one detected 540 with 0.33%, but the European one follow-up was 8.8 years. I'll present more data coming up. Prostate cancers detected in the screening group were 77.4% and 8.2% in the European one. And in the control group, the prostate cancers detected were 6% in the American and 4.8% in the European. The overall prostate cancer detected was 6.7% in the US study and 6.3% in the European study. Non-compliance rate was 15% for the American and 18% for the European. Contamination was 52% in the American and 20% in the European. The relative reduction in prostate mortality was insignificant in the American study and 20% in the European study. The absolute reduction was insignificant in the American study and 7.1 per 10,000 men in the European study. After 10 years of follow-up, the prostate cancer deaths increased to 174 in the US study, with 0.23% of the population having died of prostate cancer, compared to 0.33 in the European. The total detected was 8.4% in the American, compared to 6.3% in the European, having the same contamination and non-compliance. Trying to compare prostate cancer to breast cancer, which have nearly the same annual new cases and the annual deaths. This is the Health Canada projections of prostate cancer new cases and breast cancer new cases and the annual deaths. The evidence for breast cancer screening versus prostate cancer screening. For studies of breast cancer of fair quality or better, the summary relative risk was 0.84%. And if we look at the European study, it was 0.8%. The number needed to screen to prevent one death from breast cancer after approximately 14 years of observation was 1,224. In the European study, it was 1,410. The relative breast cancer specific mortality was decreased by 15% for follow-up analysis and 20% for evaluation analysis. The European study cited a 20% relative reduction. The absolute mortality benefit for women screened annually starting at the age of 40 years is 4 per 10,000 at 10 years. The absolute risk reduction for prostate cancer is 7.1 per 10,000 men in the European study. Conclusion: the two large trials have mixed results. The PLCO, which is the American study, has deficiencies. They used the PSA cutoff value of 4, while the European one used 3. There was a contamination, which is screening in the control group, of 52% in the control group. All 44% of all subjects had undergone one or more PSA tests at baseline, thus screening a population who had already been screened. As a result, the events were low in number. Possibly, there was improvement in the prostate cancer therapy over the course of the trial, leading to fewer deaths. And the follow-up was not long enough to detect the difference between the two arms of the study. The European study showed the modest absolute risk reduction for prostate cancer of 7.1 per 10,000 men, but also leading to overdiagnosis and overtreatment. Therefore, we need to uncouple the diagnosis from treatment. Thank you very much.